Hi everyone, very good evening. Thank you for joining the webinar, Importance of Bubble CPAP and HFNC in Neonates. I would like to thank Dr. TJ Antony and Dr. Naveen Prakash Gupta for giving their valuable feedback on this bubble CPAP and the HFNC in the neonates. Sir, I would like to Dr. Anthony, I would like to hand over the mic to you so that you can introduce Dr. Naveen and yourself, and then we will proceed. In the end, we will have the questions in the by the panelist. So if you have any question, please type the question in the QA box or in chat. We'll take those questions in the end of the session. Thank you so much, sir. Sir, over to you.
Thank you, Himanshu. And let me start by thanking the organizers for organizing this webinar on the importance of bubble CPAP and HFNC in newborns. Most of us attending this webinar would already know most of the advantages and the importance, but it's a good idea to recollect all these advantages. We have a wonderful speaker, Naveen Gupta. Naveen did his MD from Surat and then did his DNB in neonatology from Sir Gangaram Hospital in New Delhi. He then went abroad to Vancouver in Canada, where he spent a couple of years getting newer skills. Subsequently, he came back to India, worked. He was together with me at Max Patparganj. And then he now heads the neonatal unit at Rainbow Children's Hospital in New Delhi. I know him well, and I know he has a great knowledge of non-invasive ventilation, especially CPAP and HFNC. So I'm not going to waste more time, and I'm going to hand over to him. Naveen, over to you.
Thank you, sir. Thank you for the kind introduction. So always a pleasure to be when I looked at the era when I was working with you. So let me start the presentation directly and without wasting any time. So, okay, is my screen visible, sir? Shall I start?
Yes, it's visible. You need to go on to slideshow. Yeah.
Okay. Good evening, everyone. So special thanks to Fisher and Peckel, and good evening, sir, and good evening all the people who have participated and who we will be doing this interactive session. And in the coming half an hour or so, we are going to discuss about the importance of bubble CPAP and high flow nasal cannula in newborns. So over the past 20 years, if we say that, if I stretch it back a little bit more, so 1990s to 2000 was the time when CPAP was evolving too much, and then a lot of data regarding the CPAP. But every neonatologist or every neonatal nurse who is using CPAP, they are encountering certain troubles with the CPAP. And then this high flow nasal cannula came, and actually without much of the evidence, this is one of the modality which was started using in the NICUs too often and too much by the practicing neonatologists, neonatal nurses, because it was very comfortable for the parents. So how this whole story evolved and what is the rationale of this non-invasive ventilation in newborn, we are going to discuss in the coming time. So let's say a very common case which we all encounter, whether we are neonatologists or we are doing the pediatrics. And the case is a late preterm baby born through the elective LSCS. Baby cried immediately after birth. When we talk about the antenatal history, so steroids were given at the age of 32, 33 weeks because the mother, she was at risk of preterm labor at that point of time. There was no history of leaking per vagina, and a delayed cord clamping was done. But in the delivery room, the baby started having breathing difficulty, and we shifted the baby to NICU post that. So in the NICU, this was the baby. So as we all can see that the baby is having breathing difficulty. Normally in our NICUs, we assess this breathing difficulty with the help of Downey score. So in Downey score, we assess by subcostal retractions, intercostal retractions, Then there are 5 components. We look at the respiratory rate, we look at the retractions, we look at the air entry, we look at how much oxygen baby is needing to maintain his oxygen levels, how much FiO2 the baby is needing, and the fifth is the grunting, whether it is audible or it is audible only by whether it is not audible, whether it is audible only by stethoscope or it is audible by naked ear. So this was the distress pattern. Just to bring the video one more time. So what are the options we have? So as a practicing neonatologist or pediatrician, the option we have is putting the baby under the oxygen hood, which we used to do many years back, or starting this baby on CPAP, or some people who feel that the baby is having too much distress, they will intubate the baby and they will ventilate the baby. So if I look at the current evidence, so the best option will be to start this baby on CPAP. Now, if we look at the baby, so till the time we start him on CPAP, the nurse put the baby under oxygen. So when the baby has been put under oxygen, you can see that the baby is maintaining saturations. The saturations is 94%. In fact, without oxygen also the saturations were very good. But look at his work of breathing. His work of breathing is still there. So what oxygen is doing is, so oxygen will help the baby to maintain the saturations, but it might not take away the whole work of breathing. Why? Because we know that why this baby is working hard or breathing hard. It is because that the alveoli are collapsed. So oxygen is not going to open up the alveoli. So let's see what will open up the alveoli. The distending pressure will open up the alveoli. And how can we give this distending pressure? We can give this distending pressure by providing this baby with the CPAP. CPAP is the continuous positive airway pressure. So why non-invasive support? If we look at majority of the breathing difficulties which occur immediately after birth, and we take apart the congenital malformations like congenital diaphragmatic hernia or the CLE or these things which are very rare. So majority of the things, the problem is with the FRC. So airway distending pressure to maintain FRC. What is FRC? FRC is the functional residual capacity. So functional residual capacity is the volume of air which remains in the lungs after a normal tidal expiration. So if FRC is good, the baby can breathe well. If the FRC is less, FRC less means the alveoli are collapsed. So majority of the air has expelled and the positive pressure which remains in the alveoli at the end of expiration, it is very less. That's why FRC is less. When FRC is less, in the next breath, baby will try to suck in more air, and that will be visible to us as intercostal or subcostal retractions or suprasternal retractions or grunting, all these things, right? So airway distending pressure to maintain FRC is the cornerstone upon which all the support modalities are built. Whether even if we are ventilating the baby, then also we have to provide PEEP. When you provide in the ventilation PEEP, that keeps the alveoli open, that recruits the alveoli. Recruiting means that the alveoli is taking part in gas exchange even at the end of expiration. If you give CPAP, then also you try to maintain FRC. If you provide high flow nasal cannula, then also one of the things which you do is you tend to provide FRC. So airway distending pressure to maintain FRC is the cornerstone things. When we look at the evidence, CPAP has come out as one of the modality which leads to decreased bronchopulmonary dysplasia at 36 weeks along with the death. Composite outcome of death and BPD is lesser in the CPAP group. Fewer airway complications. When you intubate the baby, nobody likes the tube in the trachea. It leads to inflammatory markers generation. It may lead to increase in the ventilator-associated pneumonia, complications, infections. So there is nothing with this CPAP. Reduced inflammation, less stress for babies, families, and staff, and obviously the cost is lower. So non-invasive ventilation, when to use? So as a primary mode in RDS, if we club all the data, less than 28 weeker baby, if we feel that 80 to 90% of these babies will have breathing difficulty, majority of them, the breathing difficulty starts in the delivery room. So preferably we should start it as early as possible, because the key point here is that if we prevent the alveoli, if we recruit the alveoli from the first breath or from the initial few breaths only, then the chances of that baby going on to the ventilator will be lesser. When we talk about 28 to 34 weeks, the baby, as soon as respiratory distress start, we should start it. More than 34 weeks, if we talk about these babies, because this is the chunk in which even if the baby will have respiratory distress, in a good chunk of percentage of these babies, the respiratory distress will settle on its own within 6 hours. We read it in textbook also. So we'll wait for 6 hours, and if distress persists, we will start CPAP. Or within 6 hours, if we feel that the distress is too much, that the baby is needing a lot of oxygen to maintain the saturation, we may intervene early also. Now, coming to the second thing, post-extubation phase, the babies in whom they have been ventilated, when we extubate these babies, there are three options. Either we extubate them to room air, or we extubate them to oxygen, or we extubate them to a device which will give them a distending pressure. It has been seen that when we extubate these babies to a device which provides distending pressure, whether that is CPAP or that is high flow or that is nasal IMV, the outcome is good as compared to extubating them on oxygen. What is the outcome? Outcome is reintubation. So chances of reintubation are lesser if we extubate them to this. So this is true when the lungs are diseased, like you are ventilating the baby for HMD, MAS, pneumonia, or any other illness. When suppose you are ventilating the baby for asphyxia, and you extubate the baby when the baby is having respiratory drive, and if the lungs are completely normal, you can even take the baby out to room air. But if he again post extubation he is having breathing difficulty, put him to nasal CPAP as early as possible. So in the post extubation phase also, if we extubate these babies to a device which will provide distending pressure, that will be really nice. Then in apnea of prematurity, when the baby is forgetting to breathe, or preterm baby who is having recurrent episodes of desaturations or apnea or bradycardia, then also in addition to the methylxanthines, that is caffeine citrate, we should provide CPAP. So now the types of non-invasive ventilation. CPAP is continuous positive airway pressure. High flow nasal cannula, we will discuss these two in details. Then nasal IPPV, if the time will permit, we will discuss little bit. Then nasal IPPV in India, when we do it, this is non-synchronized. In India, we don't have the machines which can synchronize it. But in West, especially in few European countries, especially from the France and Italy, there are machines where there is synchronized nasal intermittent positive pressure ventilation. And then very less people, I don't have experience in this, they use the nasal high frequency ventilation also. So we will discuss mechanism of action, rationale, challenges for clinical research, and eventually the question comes that which mode of NIV to use in which setting, or does it matter at all or not? So rationale, I tried to explain also that when we provide a distending pressure, it recruits the lung volume. Recruitment is that the alveoli are taking part in gas exchange. It increases and it stabilizes the FRC. So premature baby, they also have a very compliant chest wall. So what is happening is that when the baby is breathing spontaneously and the baby is during inspiration, baby is generating a negative intrapleural pressure, then because of the compliant chest wall, the chest retracts. So you could see that there is a retraction. When you provide CPAP, then because of the distending pressure, it splints the chest wall and that component is gone, and then also the baby can breathe comfortably. Similar thing happens to the airway. CPAP, by splinting the airway, prevent the collapse of the airway during the expiration, so thereby helping in apnea of prematurity and thereby helping in few of the malaisias if some baby has got a little bit of tracheomalacia or the bronchomalacia. It improves the lung compliance, it decreases the airway resistance, decreases work of breathing, and eventually improves the gas exchange and reduces apnea also. Is there evidence for it? If we club the evidence over the past 20 years, majority of these trials, they are one of the best done trials in neonatology, and their research question was CPAP versus ventilation. So one group, they give CPAP, other group, they ventilated the baby immediately in the delivery room. The population was 25 to 28 weeks. So that's a very, very immature population. And these trials have been done in different parts of the world, like Support was mainly an American trial, COIN was mainly a Australian trial, VON, again America, Vermont Oxford Network Database, CurePep was the European trial, and this Neonates was the South American trial. And when we club all these data, we could see that the composite outcome of the death or BPD was lesser in the CPAP group, although the confidence interval is nearly touching 1. So CPAP has come as one of the modality which decreases the composite outcome of death or BPD at 36 weeks. So now when we talk about how can we provide CPAP, so there are options. One is the ventilator CPAP we can provide. So almost all the neonatal ventilator, they will have the CPAP mode, and you can provide CPAP with the ventilator. How does the PEEP is generated in this? PEEP is generated by the partial closure of the expiratory valve. When you look at your ventilator, in all the ventilator, there is an expiratory valve attached. If the expiratory valve is fully open, then the PWP will be 0. If you keep the PWP at 4, it will be little bit closed. At 5, it will be more closed. 6, more closed. So when the partial exclosure of the expiratory valve, what happens is that the resistance in the expiration is more. When the resistance is more, then the alveoli, they don't tend to collapse. So here I should explain also that why do babies grunt? So grunting of the baby is a compensatory mechanism in which the baby tries to avoid closure of the alveoli. So that's why in that effort, the grunting is generated by the partial closure of the vocal cords in the expiration. So in the expiration, when the partial closure of the vocal cord is there, that's why the resistance during the expiration is increased and pressure is generated and baby grunts in that effort. So the same thing we are replicating artificially, whether that is in the ventilator CPAP or the bubble CPAP or variable flow CPAP. In ventilator CPAP, it is the expiratory valve which closes the partially. In bubble CPAP, we do the same thing by dipping the expiratory limb in a water chamber. The extent to which it is dipped in the water chamber, so that extents become our pressure. So that pressure is generated, and then baby has to expire against that pressure. And in that effort, the work of breathing is good, because the alveoli, it doesn't collapse. So in bubble CPAP, PEEP is generated by immersion of the expiratory limb in the bubbling chamber. And in variable flow CPAP, these are the flow drivers. I'm not going to talk much about it. In 2000 or 2005, they were new kid on the block and they were very favored. But then the data came and it was found that bubble CPAP is equivalent to the variable flow CPAP, and variable flow CPAP, being expensive, is now has now become out and out of the neonatology. Especially in our country, we feel that bubble CPAP is a very good thing. So variable flow CPAP, infant flow driver, there is a Coanda effect by which the work of breathing is less. Okay, anyhow, coming to the bubble CPAP, a simple and inexpensive thing. So bubble CPAP setup should be there. So let's talk about the setup. What are the prerequisites? So one is the compressed source of oxygen and air. So always remember that in your NICU, there should be a compressed source of oxygen and air should be there. If compressed source of air and oxygen are not there, you cannot provide the CPAP. And suppose I have seen few units in which people only provide it through the oxygen. That is also not right. That is actually very bad, because then you will be providing the baby 100% oxygen. And if you give CPAP with 100% oxygen, so take it that it is nearing a crime. It's not good for the child. Okay, so compressed source of air and oxygen is important. This compressed source can be a centralized supply of air or oxygen, or it can be through the pressurized cylinders also. In cylinders, you have to change them frequently. That's the only drawback. Now, this compressed source of air and oxygen, they have to mix. So for mixing, there is a blender which comes. Okay, so blenders are formed by different companies. So you can use the blender. Blender has a knob in which it will go from 21 to 100%, and you can set the desired FiO2. Suppose you feel that the blender is expensive. So the key message here is never give CPAP without blender or without mixing air and oxygen. You will be doing more harm than good. So I will come to the blender part a little bit later. Then the air and oxygen which is blended, now that air and oxygen is a cold air. So air which is kept in the pressurized cylinder, the air is very cool and dry, because unless and until they make it cool, they drop the temperature of the air or oxygen, they drop the temperature of the gas, and they make it dry, they take away the water vapors, they can't store it, because a warm and humidified gas, it expands. You can see that suppose when the water is boiling, the steam, it expands. So if the gas is warm and the gas is humidified, it will expand. So they can't store it. So for storing it, they have to drop the temperature. So the oxygen or air which is coming out from there, it is cold as well as it is dry. So if that cold and dry thing goes to the baby's ear and the baby's lung, so it will destroy the cilia, it will increase the risk of infection and blah, blah, blah. And even if you will keep it adjacent to your nose, you will see that you can't even tolerate it well. So it has to be warm and humidified. There comes the role of the humidifier. So there are different humidifiers are available. Even nowadays, I'm not going to talk about that, but nowadays fully automated humidifiers are also available. This is also sort of a fully automated humidifier. So this is the green tube which is attaching here. This is coming from the blender, and then it gets humidified and warm, and through this blue tubing it is being delivered to the baby, and this white is the expiratory limb. So then comes the interface. So interface can be nasal prongs, it can be nasal mask. There was a time when nasopharyngeal tubes, single side were used or double side were used as an interface. So the key message here is that leak should be minimum at the interface so as to provide a good distending pressure. One is this. Second is, if you are using prongs, then short binasal prongs are the most effective one, because if the length of the prong will be lesser resistance will be generated, meaning that the baby will have to work less hard. Okay, because the narrowing of the airway will be lesser. So short binasal prongs are good, but short binasal prong have not been so much evidence is not being compared between the mask and the short binasal prong. There have been few small studies, but this needs to be worked a little bit more. We, as our unit, we are very comfortable with the mask one. So we have started using these nasal masks because nothing goes inside the baby's nose and the work of breathing is slightly less. So you can use either the short binasal prong or the mask. Okay, so this is the interface. The key is that the leak around the interface, leak around the mask or the short binasal prong should be the lesser. Then if you don't have a blender, suppose you can't spend so much money in that, so you can keep this chart and always remember this formula. So in the formula, suppose you are giving 4 liter of air and 4 liter of oxygen. Always remember that in air also there is a 21% oxygen. So you have to multiply 0.2 into airflow, 0.2 into 4 plus oxygen is 100%. So 1 into 4. So this will become 4.8 divided by the total flow, that is 8. So it is 60%. So if you are giving the same amount of air and same amount of oxygen flow rate, 4 and 4, 3 and 3, then the FiO2 will be giving, it will be 60%. So this is a chart in which you can adjust. Suppose you want to give 40%, you know that how much air to give and how much oxygen to give, 50%, 80% or 90%. So you can keep this and you can have this formula also. And if you can have blender, that will take away this job and that will do the job. So these are the interfaces. As I explained you, the short binasal prongs are good. So these are Hudson or the Neopap prongs. Then there are one Fisher-Paykel prongs also. There are few other made by the companies also. These are the baby caps which are necessary. And these prongs, they are used for the high flow, heated humidified high flow nasal cannula, which we will be discussing later. So this is also from the Fisher-Paykel. This is OptiFlow from the Fisher-Paykel. This is a RAM cannula. And for the RAM cannula, you need a T-piece connector also. For this also, you need a T-piece connector. Okay. So how do we know that the CPAP is working? So when you put the baby on CPAP, remember, why did you put the baby on CPAP? Because the baby was breathing hard and the work of breathing was too much. So first thing is that the baby should be comfortable. He should be breathing well. The retraction should be lesser. The work of breathing is less. And always remember that when we are putting the baby on bubble CPAP, the bubbling should be there in the bubbling chamber. If the bubble is not there in the bubble chamber, that means the positive pressure is not there. Either there is a leak around the interface, or there is a leak somewhere in the circuit, or the flow is insufficient. So always remember that bubbling is flow dependent. Like let's assume a situation that PWP is set at 5. Different PWP will be delivered if the flow rate is 5, 7 or 9. Let's assume that bubbling is there at 5 also, at 7 also, at 9 also. Then maybe at 5, the delivered PWP is 5, but at 7, although the set PWP is 5, but the PWP which is going to the baby, it may be 7 or 8. At 9, it may be 8, 9 or 10. So it is always important to look for the bubbling. Bubbling on one side is important. Second side, it should not be excessive. So the rule is that minimum flow should be kept so as to generate the continuous bubbling. Like this baby, we put on the nasal CPAP and the baby is comfortable. You can see now, this was the thing which I was talking to you, bubble CPAP versus ventilator CPAP. So just a minute. Okay. So bubble CPAP pressure is flow dependent, as I was explaining to you. See here, the mean pressure is 4, right? And as you increase the flow, look at the pressure. So at 6 liter, the pressure is different, although the set pressure is same. So the orange line is the bubble CPAP. So as you increase the flow, the pressure increases. And in the ventilator driven CPAP, because it is not flow dependent, so the pressure remains the constant. So troubleshooting, bubbling should always happen. CPAP is being delivered only if bubbling is happening. If bubbling is not happening, check for the leak somewhere. Mostly it's at the interface level. If there is no leak, then increase flow to ensure adequate bubbling. Like, let's look at this. So this is the continuous bubbling which is there, and continuous bubbling, and the flow is 7 liters, right? So let's look at bubbling is adequate, no change needed. Let's look now. Now there is no bubbling which is happening. So you can see the water column which is moving with the inspiration and expiration. So maybe there is a leak at some place. So what's happening? No CPAP being delivered, action needed, check for the leak, increase flow if there is no leak. Okay, now this is an inadequate leak. Okay, at the same flow. So inadequate bubbling, what's happening? CPAP being delivered is lesser than set CPAP. Action needed is check for leak, increase flow if there is no leak. Now look at this now. So the bubbling is too much. It's a continuous bubbling. It is so much that it is raising the water column. Why? Because somebody has inadvertently increased the flow rate. So what is the action which is needed is CPAP being delivered is maybe higher than the set CPAP. So action needed is decrease the flow rate. Okay. So let's see how do we put the baby on nasal CPAP. First of all, so we will just go quickly through it. So this is the equipment which is needed. You will measure the head circumference. You will measure the appropriate size interface which is needed. Then you make the baby wear this cap, right? Based on the head circumference, you will make the baby wear this cap. And once we make the baby wear this cap, we will put the so to protect the so basic thing is that we have to protect this area. So when we are using short binasal prong, then the nasal septum injury is very common. When we are using the mask, then the injury happens at the level of the bridge of the nose, because that is the point where the compression comes too much. So many a times we have to see that how can we avoid it. Maybe after every 4-6 hours we can release the pressure a little bit and we can suction the nose. So this is all nursing care which is very important, and this is how you are going to put the interface, right? You are going to put the interface and then see how do you so somebody will hold it from here, and then we will yeah.
You keep on holding from here.
So then see the key here is one person has applied pressure from the top, and then once we attach this Velcro, one person will apply the same pressure from the both sides, so that the balance remains in the midline. The interface is not deviated to one side. See, See, from both the sides, the same person is putting the pressure, and then he or she is attaching the Velcro, because this is a very, very small baby. So you can see that on the upper lip, the interface is coming. So you can adjust that little bit, and gently you can put the shoulder roll, and you can make this adjustment. Right. This has to be done with your gloves on, and the sterile conditions are very important.
Stretching both the ways and then stitching it and then keeping it like this.
Okay. So, okay. So see, the baby is now comfortable, and you can see the saturations, etc. They are good. Okay. So all devices, they are not the same. When we talk about bubble CPAP, bubble oscillations, they may improve lung recruitment. There was a suggestion that in bubble CPAP, because of the oscillations generated, they may improve the gas exchange better. Bubble CPAP pressure delivery is flow dependent and not reliably delivered related to the liquid depth. So we have seen that, and bubble CPAP pressure delivery varies more than the variable flow. So when we talk about the CPAP guidelines, now it remains a mystery how much pressure to start. Majority of the units, they start at a pressure of 5 to 6 centimeter of water. The flow rate which is put is 5 to 8 liters per minute. We should ensure no leak and continuous bubbling, and the FiO2 to maintain saturation is between 91 to 95%. How to ensure optimum PEEP? Clinically, we will look that there is decreased work of breathing, monitored by the Downey score or the Silverman-Anderson score. Improvement in the perfusion will be there. The baby will be pink, baby will be comfortable, oxygen saturations will be good. And when we do an X-ray, we will see that the FRC is good. So how do we check FRC on X-ray? So when we count the posterior end of ribs which are attached to the vertebra, the diaphragm should be at the level of 7 to 9 posterior end of the rib. Or when we talk about anterior end of the rib, it is 4 to 6 anterior end. If we talk about the posterior end, if the diaphragm is below 9th rib, then you may tend to decrease the PWP. And if the diaphragm is above the 7th rib and lungs are too much hazy, you may choose to increase the PWP by 1. So what do we do if there is no improvement? So mainly in RDS, you will increase the PWP by 1 to 2. So maximum you can go till 7 to 8 centimeter of water pressure, depending upon unit to unit. FiO2 you increase by 5% and maximum 80%. Although in our unit, we go maximum only 50%, and then we choose to intubate the baby. Apnea of prematurity, you may increase the pressure to 5 to 6. Further increase may lead to hyperinflation. FiO2 increase doesn't help if the baby is totally apneic. Post extubation, you increase again same as RDS by 1 to 2 and maximum up to 7 to 8, and FiO2 you increase by 0.05 and maximum 0.8. Range of PEEP less than 4 is bad, more than 8 is bad. So 4 to 8, most of the people like it. Adequacy of CPAP, satisfactory cardiorespiratory status is important. Baby should be comfortable, minimal retractions, no grunt, capillary refill is normal, blood pressure is normal, good saturations. And normally we don't do repeated blood gas when the child is on CPAP. However, if you do a blood gas, the norm should be acceptable, like permissive hypercapnia, when you can accept a PCO2 of 60, pH of more than 7.25 is good, and PO2 of 50 to 70 is good. So how do we wean from CPAP? So, so in RDS, we say that the child doesn't have any respiratory distress, saturations are good, then we tend to wean. Apnea of prematurity, the baby doesn't have any apnea, desaturation for at least 24 hours, and post extubation, the features remain same as RDS. So how to wean depends on the underlying condition. First, reduce FiO2 in a step of 5% and let it come less than 30%. And then we decrease the pressure in step of 1 to 2 centimeter water until 4 is reached. If PEEP is 4, FiO2 less than 30%, clinically well, that is no respiratory distress, saturations are good, normal blood gas, we remove CPAP. So although everything looks so well for the CPAP, but everything in this world, if it has got something good, it has got something bad also. And we always have to weigh the good things apart from the bad things. So what are the problems we encounter with the CPAP? Whether we use nasal prongs as an interface or the mask, it is discomfortable for the child. So nowadays, when we are advocating early kangaroo mother care with the mother as soon as the baby is hemodynamically stable, If the child is on CPAP, it is difficult to do the kangaroo mother care. Nasal injury, so I told you that with the short binasal prong, it's mainly the columella or the nasal septum which is injured badly. With the mask, it is mainly the bridge of the nose, at the bridge of the nose where the injury happens. So nasal injury is also a problem, and sometimes because the distending pressure is also going to the belly, so the belly becomes distended, although the risk of NEC doesn't increase, but yes, it may lead to feed intolerance, and sometimes you have to stop the feeds. So CPAP as a gold standard has been compared with the high flow nasal cannula, which has gained more and more popularity in the last few years. So high flow systems, how are they different from the CPAP system? If I revise the CPAP system, I will tell you the difference. So we need a compressed source of air and oxygen, same here. Then something has to mix it. So blender, we do need it. Then because this is cold and dry, this has to become warm and humidified. So we need a humidifier. Then we do need an interface, but there is no expiratory limb in the high flow systems. Always remember that. So say this is a high flow system. So from the blender, this thing goes here and then warm and humidified, and there is only a blue single inspiratory limb. There is no expiratory limb. So how does high flow nasal cannula act? High flow nasal cannula, apart from providing little bit of distending pressure, it has a gas conditioning effect, and it washes out the nasopharyngeal dead space. Normally in this nasopharynx, the dead space is there where the CO2 is there, so it washes out the nasopharyngeal dead space at the high flows. It reduces inspiratory resistance, resistive work of breathing, and less breathing CO2, possible Coanda effect also, as it was there in the Coanda effect was there in the variable flow CPAP, which we did not discuss. Pressure effect does provide distending pressure, highly dependent on the prong to nair ratio and degree of mouth closure. Always remember one thing. In CPAP, I was emphasizing this more and more, that in short binasal prongs, if you are using, then there should be no leak. So that means that if this wide, they are then internal nair. In the CPAP, there should be no leak. In high flow, the diameter of the high flow nasal prong should be 50% of the nair diameter. So there should always be a leak, because if there is a no leak in high flow and the baby closes to the mouth, the whole of the flow will go inside the lung and the lungs will blow out. There will be air leaks. So because there is no expiratory limb in CPAP, because the expiratory limb was there and it was dipped in the water chamber. So it was dipped in the water chamber. So there was always a release thing. So here, where is the release thing? When the prongs, they are not snugly fitting the nairs, so then the air leaks from the sides. So who is using high flow nasal cannula? I am talking to you about 2010, when the evidence also was not so strong for high flow nasal cannula. But in these surveys, 66% of US unit, Australia, New Zealand, more than 80% of the UK units, they were using high flow nasal cannula. So why it was being used so often? Because easy to use, safe, decreases work of breathing, nurses love it, babies are more settled, less CPAP belly, less nasal trauma, practically no nasal trauma with high flow, no pneumothoraces. So we talk about high flow nasal cannula interfaces. Then the first blue one is the Fisher and Paykel, second is the OptiFlow. We in our unit use this because we feel it very comfortable. The prongs are very, very soft. And then this third one is the RAM cannula. In many parts of the world, this is also being used. So interfaces, I talked to you about, this is the RAM cannula, this is the Fisher-Paykel OptiFlow. And then again, with the RAM cannula, so sometime, and we do sometime with the OptiFlow also, we use the expiratory limb also, but the high flow nasal cannula were devised in which there was no expiratory limb. So where all high flow nasal cannula has been tried, it has been tried as a primary mode in RDS, avoid post-extubation failure, apneas, baby requiring prolonged CPAP. So when we talk about this, this was an old Cochrane review, and we talk about high flow nasal cannula as primary RDS. So insufficient evidence to establish the safety or effectiveness as a form of respiratory support in preterm babies when used following extubation. Always remember that following extubation, it may lead to higher rate of reintubation than nasal CPAP, But I will come to an equivalence trial which was done in which it was equivalent to nasal CPAP. However, I will come to this point. I will come to this point. So there is not sufficient evidence. So in post-extubation care, where we have found that high flow nasal cannula has got too much of a role. So in post-extubation care, so they found that there was no difference, less nasal trauma, no difference in intubation in 72 hours. And then there was a large trial, and this was mainly trial by the name Hipster trial. So in this, it was an equivalence trial, 303 babies, less than 32 weeks, PME less than 36 weeks at the time of extubation. Primary outcome was treatment failure in 7 days, and non-inferiority margin was 20%. And there was no difference. But what they found was that high flow was not as good in babies less than 26 weeks. So more premature a baby, it's not so much good thing because it provides less distending pressure. And 50% of the babies who fail on high flow avoided reintubation if they were put on CPAP. So their study protocol was this, that post-extubation, half of the babies were extubated to high flow, half of the babies were extubated to CPAP. Now, if the CPAP baby fails, he was reintubated. If the high flow baby starts failing, he will first go to CPAP and then to reintubation. So this is the same thing which we should follow, because they found that 50% of the babies on the high flow, so they were failing on high flow, but once they put on CPAP, they avoided reintubation. So as a post-extubation measure, you can extubate these babies on high flow, but if they fail, you can put them on CPAP. So practical guidelines for high flow: must maintain leak at nose, very, very important. Always remember this. Keep a temperature close to 37 degrees by warm and humidifier, and position tube down and away from the baby. So like this, if this is the scenario in which the nasal prongs are covering the whole nair, this is very bad. This is very good. A happy going kid in which the nasal prongs, they are covering 50% of the internal diameter. So this is good. So what flow we should start at in neonatology? We are using a flow of 5 to 8 liters per minute. In pediatrics, even more flows are being used. Increased you can flow depending upon the FiO2 needs, workup breathing. It's a non-invasive treatment. Treat it like CPAP. Titrate FiO2 first and then the flow rate. If FiO2 need is 50 to 60, more than 50 to 60%, go to CPAP and then intubation. So as a conclusion, as a primary mode, CPAP is good. Post-extubation, CPAP or high flow nasal cannula you can use. In case the baby fails on high flow nasal cannula, shift to CPAP first before intubation. Nasal IPPV do have role in cases where the babies are failing on CPAP before intubation. Like we go to nasal IPPV also if the baby is failing on CPAP before intubating the baby. So these are nasal IPPV in which you have to fix the rate. It is like you are providing a positive airway pressure through the nose. So there is a rate also, that how many times in the minute you are providing. There is an inspiratory time also. There are PIP and PIP, PWP also, and obviously FiO2 also. So nasal CPAP and IMV. So basically, you can see that in CPAP only one line is there, that is the PWP, and in IMV, in the nasal IMV, so you can see that PIP is also there, graph is going, and PWP is also going. So that's the difference between the two. So practical guidelines. So these are a few of the settings which you can use while using the nasal IPPV for RDS and for extubation. This has been taken from Dr. Alan Jobs' article. So nasal IPPV benefits over CPAP. It can decrease asynchrony and increases tidal volume. MV decreases work of breathing. No reports of NEC or GI perforation. When we look at the evidence, so for post-extubation apnea, it may augment the benefit of the nasal CPAP, reduces incidence of extubation failure, reduces frequency of apnea. However, additional safety and efficacy data is there. Then so coming to the last talk, last slide. So suggestions are: nasal CPAP is gold standard for RDS. High flow we can use in post-extubation, babies having less trauma. Another thing in which we use high flow is many feeder and growers, when they are little bit desaturating and they just need a little bit of pressure. We use high flow because we give them KMC and there is no nasal injury. Baby is very much comfortable till the time they are matured more. Like just to give you an example, 26 week where baby is born, he started on CPAP, he failed on CPAP, he was intubated. Post extubation, we first bring him down to nasal IPPV, then to CPAP. And after week to 10 days, when he's comfortable on CPAP, but we feel that he's still immature and he is having little bit of apneas or brady's or desaturation, we put the child on high flow nasal cannula so that he's comfortable. The mother can start doing KMC and then he remains on high flow nasal cannula for 3-4 weeks or whatever time. Always remember, if the baby in the post-extubation stage fails on a high-flow nasal cannula, start CPAP before intubating. And nasal IPPV use can be considered in the post-extubation phase, and more machines and better synchronized methods are required in our country. Thank you very much for the patient listening, and I would be really happy to answer any questions.
Thank you, Naveen, for this wonderful talk. You covered this huge topic in about 45 minutes very well. You covered most of the practical aspects, which is what I think most of us need. The theory, I think most of us can read. There are plenty of material available everywhere. You covered the practical aspects very well. So thank you for that. Let me see if there are any questions. There was one question that I saw, and this was from Dr. Payal Puri. And she asked, can we use RAM cannula with CPAP? As the baby is most comfortable in this. What would you like to say?
Yeah, thank you, sir. So, hi, Dr. Payal. Hi, how are you doing? So, a very relevant question, Dr. Payal, you have put. So, we can use CPAP with the RAM cannula, but always remember the principle of the CPAP, that there should be no leak around the interface. So, if you are using CPAP with the RAM cannula, you have to use a size more so that there is no leak. Because if there will be leak around the RAM cannula, then the bubble will not be generated in the expiratory limb. So you can use that, but always remember this thing. So always with the high flow nasal cannula, when the RDS is too much, when the oxygen needs are too much and severe RDS, the distending pressure is not there. That's why we have seen that the many babies fail. Even we generated our own data also when I was in Max Papadganj. And although we didn't publish it, but we presented in conference, and our findings were also the same.
Naveen, you talked a lot about high flow nasal cannula, using that to as a method of treating babies with respiratory distress. But you didn't mention anything about how you would wean the baby off high flow. Do you wean them off, or do you take them off suddenly? What would you do?
So nice question, sir. Yeah, I think it was I missed that slide or just forget. So in high flow nasal cannula, again, when the child is on high flow nasal cannula, first we titrate down the FiO2. Once the FiO2 settings are less than 30%, then we tend to decrease the flow. Like if the baby is on a flow of 8 liters per minute, we will try to decrease it by 1 liter per minute every 12 hourly, like 8 to 7, 7 to 6, and 6 to 5. And then at a flow of 5 liter, we discontinue the high flow nasal cannula.
Thank you, Naveen. And I have one other question. Can we use the same circuits for high flow and for nasal CPAP?
So technically not, sir. So technically, because the what should we say? There's something which comes on the which is there on humidifier, which has got a pop-off valve. So that has been color coded also, and that is different for the CPAP pressure and the high flow pressure. So we should not use that. Yeah.
So So as far as the Fisher-Paykel circuit is concerned, there are two different circuits for high flow. I mean, a different circuit for high flow and another circuit for CPAP. The valves on them have different pop-off pressures, and so one should be careful when we use a circuit for one or the other. Yeah. Let me just see. I think there are a couple more questions. So there, Dr. Ajay Kumar wants to know, can you explain about Ram's cannula? What PEEP should be kept if we're using it on a ventilator CPAP?
Okay, so sir, if you are using RAM cannula in a ventilator CPAP, So the PEEP will be the same. PEEP will be the same, whatever you think about, depending upon the baby illness. Like we say that 5 to 6 is a good starting pressure for PEEP, so you keep the PEEP same. Just remember one rule, that while using RAM cannula, majority of people don't follow it, that there should be no leak around the interface, and there is some way of judging that the pressure is generated or pressure is being delivered to the baby's chest. Because in CPAP, the only mode, how does it work, is by the descending pressure. High flow, that's not the case. Like RAM cannula was originally designed or devised for the high flow thing. And in high flow, the gas conditioning mechanism, washing out of the nasopharyngeal dead space, they are the predominant mechanism by which they are helping out the baby. They also generate little bit of descending pressure. So if you remember this difference, you can use any interface. So the PEEP will remain the same.
Thank you, Naveen. I don't think we have any other questions. Since we have no other questions, I think let me thank you once again for this lovely talk. Thank the organizers for organizing this webinar. Yeah, thank you very much, and over to you, Himanshu.
Thank you, Dr. Naveen and Dr. Anthony, for taking out some time and sharing your experience on the bubble CPAP and HFNC in neonates. I would like to thank both of you on the behalf of Fisher and Pickle team. And with this, we conclude our session. Thank you so much, participants, who joined this session. Good night. Take care.
Thank you. Thank you, sir. Thank you, Fisher and Pickle team.
Thank you, everyone.
Bye. Good
Bye.
night.
Good night.
Thanks a lot.
Yes, sir.